I'm Nicole Lamana, Associate Professor of Medicine at Columbia University in New York. And I'm joined today by my colleague and friend, Dr. Nitin Jain at MD Anderson. Nitin, if you want to do a better introduction than colleague and friend, please do so.
That's great. So myself, Nitin Jain, at the Department of Leukemia at MD Anderson Cancer Center in Houston, and I treat patients with CLL and also run clinical trials for patients with CLL.
And so here we're bringing together a sort of virtual ASH, little updates from some of the presentations that we had just recently at the ASH 2021 meeting. And I'm talking to Nitin today about a combination strategy of looking at some of the CLL drugs, but combined with a PD-L1 inhibitor for patients who are getting, who need their first treatment for CLL. And Nitin, let's tell us a little bit about the trial and the combination and why you chose to do, combine sort of therapies that we know for CLL along with a checkpoint inhibitor.
Sure, yeah. Yeah, so the trial we're discussing is a trial which has three drugs involved. One is Venetoclax, which is an oral pill approved for CLL. One is Obinutuzumab, which is CD20 antibody approved for CLL. And those combination of Venetoclax plus Obinutuzumab is an approved strategy for CLL patients. Many of the patients may be receiving it from their doctor. What we did in this trial is that we know that this combination of Venetoclax obinutuzumab works, but there were some lab data to suggest that adding a checkpoint inhibitor can increase when you combine a checkpoint inhibitor, which is the molecules expressed on the immune cells, and if you block and they inhibit those immune cells. So if you give a drug which gets rid of that immune cell inhibition, your immune cells will get activated. And when you do that in combination with Venetoclax, there is some synergy together. And this was showed in a lab model. And there was also some studies which showed that if you combine antibody, like CD20 antibody with a checkpoint inhibition together, there is some synergy as well. So we felt that if we can do a trial where patients will get what is standard of care, like Venetoclax plus obinutuzumab, but we'll add an immune antibody, this checkpoint inhibitor on top of it, to see if we can increase the number of patients who will get what is called MRD negative remission, where you do a bone marrow or you do a blood test and you're not able to find any cancer cells in 1 in 10,000 cancer cells that you counted. So that was the kind of the genesis or the rationale for doing the trial. So the trial is an ongoing trial at MD Anderson. We treated about 30 patients so far. Our goal is to treat 45 patients. So these are all frontline newly diagnosed patients who need treatment for their CLL. And what we have seen so far is that compared to other patients we have treated or other patients in the medical literature which have been treated with just the two drugs together of Venetoclax plus obinutuzumab, when you add this immune antibody on top of it, we're seeing earlier and faster bone marrow remission. For example, within 3 months of all the three drugs together, 90% of the patients were in the bone marrow negative for this, what is called MRD. So high rate of bone marrow remission very early on, within 3 months of the three drugs together, which appears numerically higher than if you just do two drugs together. So we don't know if three drugs are going to be better than two drugs, but at least maybe there's a suggestion. So far the trial is ongoing. Now, one of the things I should mention is that because there are complications with immune drugs, which is what is called itesis, meaning that immune activation can give you skin rash, can affect your liver, potentially can affect the kidney, can affect the lungs. So there are a lot of immune reactions which could happen. And not surprisingly, we had few patients who had this immune reactions. One person's kidney was affected, so we had to give steroids. Then finally, all went okay, kidney function recovered back. One person has some issues with colitis, inflammation of the colon, and we had to stop the drug, but now he's better. So those are, I guess, not totally unexpected, but we did see some immune complications. But so we have to see now what will happen to these patients long term, right? I mean, all these patients finished 1 year of therapy, and now they're just being monitored off therapy. And we'll have to see how durable these remissions are if these three drugs are doing anything better than what we would expect with two drugs alone. So that's what we presented at the ASH meeting.
And obviously, so for patients, the good news is, with all of these therapies, the Venetoclax being one of the standard treatments that we use for CLL, of course, you know, um, clearly patients are doing better with these targeted therapies. And so this combination that you're looking at is trying to see, can this do better than the, Venetoclax obinutuzumab that's already FDA approved, as you noted? Can you get deeper remissions, and will that translate into a longer response duration? Or could that, Dr. Jane, do you think that could be, maybe even particularly better for, depending upon, so if we break that down, maybe there are some subgroups of patients within CLL that might benefit more from this sort of, because as you said, there are some side effects, right, Nitin? So
Yep,
the
yep.
question is this, will this benefit maybe different individuals who might have higher risk disease, or in the end, how could this potentially be beneficial to the CLL patient?
Yeah, I think that's a question. I think this coming year, as we see these patients a bit longer term to see, and when they're off therapy, we're watching their what is called MRD in the blood every 6 months. So we'll have to see what happens in the next 1 to 2 years with the patients we have enrolled and who have finished therapy. And then if the patients were to start relapsing, then we have to figure out which patient benefited the most, and maybe that's the group of patients maybe we should look into it. Certainly we have to balance, as kind of mentioned, about the side effects as well, right? So if we are seeing some really durable remissions for majority of the patients, then maybe the side effects we are experiencing may be okay. But if you're not seeing some significant improvement than what we would expect with current FDA approved standard, then maybe we need to rethink about the strategy and maybe think about which patients really benefit the most, and maybe we should focus on that. So the trial, as I mentioned, it's so we have, I think we'll have another 6 months or so before we finish the accrual on the trial completely. And after that will be another 1 or 2 years of follow-up to see how these patients kind of do.
Yeah, fair enough. And I think it's really nice to, obviously we have great therapies for CLL patients, but we're trying to always see, are there different ways we can tweak the options that are available, and perhaps, do better than what we're currently doing. And here you're looking at things differently by adding a checkpoint inhibitor to this combination to see if we can, sort of strike it in a little different regarding their immune cells, and seeing if that enhances their response, or there's synergy between the two drugs that we currently have FDA approved.
Right. Right.
So stay tuned. Early trial, promising work, and potentially, who knows, there could be advantages in the future for certain subsets of CLL patients with long-term follow-up, depending. Very good. Thank you.
Thank you.